All right, welcome back to the deep dive. Today, we're taking a focused look at some really critical concepts in upper limb trauma.
Yeah, specifically, we're zeroing in on distal humerus, capitellum, and olecranon fractures.
Exactly. And this deep dive is structured particularly with orthopedic residents in mind. Especially those of you gearing up for postgraduate exit exams like the FRCS or other equivalent fellowships.
Absolutely. And just to be clear, all the information we're about to unpack comes from the Ortho Made Simple notes. You can find them on the website mokyingren.sg.
That's right. And these notes were put together by Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore, and he finished his FRCS back in 2022.
So a really solid contemporary source for this stuff.
Our mission here is basically to synthesize the essential info, the classifications, the management details, those sometimes tricky controversies straight from these notes.
The idea is to help you consolidate your knowledge efficiently, for when it really matters, like exam day, or when you're making those clinical calls.
Okay, so let's jump right in. Distal humerus fractures first.
Sounds good. So thinking about the anatomy, it's useful to picture it as basically two columns. You've got the medial and the lateral columns.
And they're connected by the articular segment, right? The sort of tie arch.
Precisely. Understanding that basic structure is pretty key to figuring out the fracture patterns themselves.
And one thing that often comes up early is nerve injury, specifically radial nerve palsy.
Yeah, it's definitely something to be aware of. It's not like super common with these fractures, maybe around 2–5% reported, but it does happen.
Especially with certain displacements, like posteromedial.
That's often cited. The good news, though, usually according to the notes, is that most of these are neuropraxias.
Meaning they tend to get better on their own.
Yeah, spontaneous recovery is common. Now, if you do need to explore it surgically, maybe you're worried about entrapment.
You can often get to it through the fracture site.
Exactly. Anteriorly, right through the fracture. You just follow it down from where it pierces the intramuscular septum.
Okay, good to know. Let's talk classification. The AO system, right? 1.3.
Yep, the standard AO trauma classification. It's fundamental. So type A is extra-articular. The fracture misses the joint surface entirely.
Simple enough.
Type B is partial articular. So part of the joint is broken, but it's still attached to one of the columns, either medial or lateral.
And type C.
That's complete articular. The joint surface is fractured, and it's completely detached from the shaft, broken off from both columns.
And this ABC really guides the treatment plan, doesn't it?
Absolutely. It dictates a lot.
So to figure out which type you're dealing with, especially B and C investigations, x-rays obviously, but...
You need more. Standard x-rays, multiple views, yes. But critically, a CT scan.
For that 3D picture.
Exactly. You needed to really see the articular comminution, the fragment displacement. You can't plan surgery properly without it for the complex ones.
Makes sense. So what are we trying to achieve when we treat these? What are the goals?
Well, the goals are pretty clear, really. You want a pain-free joint, obviously. It needs to be stable.
And you need that articular surface put back together as perfectly as possible.
Anatomical reduction, yeah. That's key to minimizing the risk of arthritis later on, and you want to allow early range of motion.
Which means stable fixation.
Right. And all of this needs to happen while, being careful to preserve the blood supply, especially to those articular bits.
Okay. So definitive management, what are the main options outlined in the notes?
Primarily, it's ORF, open reduction, and internal fixation. That's the go-to for most displaced fractures that are fixable.
Right.
Then you've got the bag of bones approach.
Sounds drastic.
Well, it's basically early mobilization without rigid fixation. It's really reserved for very low-demand patients, maybe medically unfit for big surgery, or with terrible bone quality.
Okay.
And the third option.
Total elbow replacement, or TER. Increasingly used, especially in certain groups like the elderly.
We'll probably come back to that comparison later. Let's focus on ORIF for now. The surgical approach is a big decision, isn't it? Especially for those complex C-types. Huge. The notes really highlight the Olecranon osteotomy for those complex intra-articular ones where you need perfect articular reduction.
Because it gives you the best view.
Unparalleled view, really. You cut the Olecranon, flip it up with the triceps, and you can see the whole discal humerus articular surface laid out.
So you can piece the joint surface back together first.
Exactly. Reduce the articular block anatomically, pin it temporarily with K-wires, make sure it's perfect. Then you fix that block to the columns with your plates, get the foundation right.
Okay. But the notes make a distinction, right, if you're thinking about replacement from the start.
Yes, important point. If you're planning a total elbow arthroplasty, Or maybe think you might have to convert an attempted ORF to a TA.
You want a different approach.
You generally want an extensor mechanism sparing approach, things like the Bryan-Mori or TRAC, or just a triceps sparing approach.
Why the difference? Doesn't TEA sometimes involve cutting the olecranon too?
It might involve a small osteotomy of the tip for access, yeah, but it's generally not the big chevron osteotomy you use for ORF exposure. Preserving that posterior soft tissue envelope and the triceps integrity is generally better when you're putting in a prosthesis.
Got it. Okay, let's get into the plating strategy for ORIF. This is where things get interesting, maybe a bit controversial.
Definitely some debate here. The notes state up front there's no single undisputed best way to pleat these. Parallel versus orthogonal configurations.
Before we compare those, the notes mention O'Driscoll's principles for plating.
Ah, yes. O'Driscoll's 8 principles, kind of the bedrock for articular fracture fixation. They break down into 6 for screws and 2 for plates.
Okay, let's quickly run through the screw ones.
Right. It's about maximizing purchase. So use as many screws as you can fit, make them as long as possible, engaging the far cortex. Try to capture as many fragments as possible with each screw.
And specifically for dual plating.
Make sure the screws from one plate interdigitate or mesh with the screws from the other plate without actually hitting each other. And critically, every single screw must pass through a plate hole. No independent screws floating around.
Makes sense for stability. And the 2-plate principles.
Use stiff plates. Think locking plates nowadays. And apply them in a compression configuration if the fracture pattern allows to add stability and help reduction.
Okay, so with those principles in mind, let's compare parallel and orthogonal plating based on the notes. Parallel first.
Parallel plating, where the plates run, roughly parallel up the medial and lateral columns. The notes suggest this offers better resistance to varus stress.
Which is important because the medial side is the tension side, right? Even just with lifting the arm out.
Exactly. Even with activities like shoulder abduction, there's varus stress across the elbow, so resisting that is key.
Okay. What about orthogonal plating? One plate posterior, one medial.
Or posterolateral and medial posteromedial, yeah. That configuration is thought to provide better torsional resistance.
But there's a downside mentioned.
Yes, a potentially significant one. Getting that posterior or posterolateral plate on often requires more soft tissue stripping off the back of the humerus.
And that matters because?
Because that's where the main blood supply to the lateral distal humerus comes from, posteriorly. That classic Yamaguchi study highlighted this. So you risk devascularizing fragments.
Ah, so it's trade-off. Torsional stability versus potentially compromised blood supply. Tricky.
It is. But the notes do give one clear indication where that posterior orthogonal plate is often necessary.
Which is?
Coronal shear fractures of the capitellum, especially if they're part of the bigger fracture pattern, you often need that posterior buttress to capture and stabilize that shear fragment. We'll touch on capitellum fractures specifically in a bit.
Okay, good link. Any other plating tips from the notes?
Yeah, using plates of different lengths is recommended.
Why is that?
To avoid creating a single stress riser point right at the end of both plates. If they end at the same level, that's where it might break again later.
So you stagger the ends. Which plate is usually longer?
Typically, the medial plate is longer than the lateral one.
Okay, and making that medial plate longer brings us right to the ulnar nerve.
Yep. The elephant in the room for distal humerus surgery. That medial plate sits very close to where the nerve runs behind the medial epicondyle.
So the big question. Do you routinely transpose the nerve? Move it out of the way.
The notes are pretty clear on this, referencing studies like Chen et al. Routine transposition is not recommended.
Why not? Seems like it would protect it.
Counterintuitively, the data suggests routine transposition actually leads to a higher risk of post-op ulnar neuritis, significantly higher in some reports, like 33% with transposition versus maybe 9% without.
Wow, okay, so what's the advice then?
Assess it intraoperatively. Once your plates are on, check the nerve. Is it sitting comfortably? Is it getting stretched or compressed? Is it rubbing directly on the metal?
And if it looks unhappy, then you transpose.
Then you consider it yes. And the notes briefly mention the types. Subcutaneous, just under the skin, intramuscular within the muscle belly, or submuscular, lifting the muscle origin. Subcutaneous is simplest.
Right. Okay, so fixation is done. Post-op plan.
The goal outlined is usually immediate protected range of motion, get it moving early to prevent stiffness.
So often no back slab needed if the fixation is solid.
Ideally, yes, if you've achieved stable fixation according to those principles. Early motion is key for elbow outcomes.
And what about complications like extra bone formation, HE?
Heterotopic ossification. Yeah, it's a known issue around the elbow. Prophylaxis is discussed. Traditionally, it was indomethacin and NSAID for about 6 weeks.
But the notes mention newer options.
Yeah, there's mention that recent literature suggests selective TOX2 inhibitors might offer similar protection against HO, but with perhaps better GI tolerance for the patient. Something to consider.
Good practical point. Okay, maybe let's pause here for a second.
Yeah.
Just a reminder, this deep dive into upper limb trauma, Humerus, Capitellum, Olecranon, is all based on the Ortho-Made Simple notes from mokyingren.sg.
Right. Now, shifting gears a bit, let's talk about a specific group. Elderly patients, say over 65, with these distal humerus fractures. The decision between ORIF and total elbow arthroplasty becomes really central here.
Yeah, this is a huge topic. The notes reference that key trial, the Machi et al. RCT from 2009, right?
Exactly. And that study really tilted the balance for many surgeons treating complex fractures in this age group. It showed TEA had better outcomes than ORIF.
Better in what way?
Superior functional scores, like the DSH score. Also, shorter operating time for the TA, and importantly, trends towards fewer reoperations and maybe even better range of motion compared to ORF and that elderly, often osteoporotic bone.
So that evidence strongly supports considering TE upfront for complex fractures in older patients.
It does. It really influences the conversation you have with the patient.
The notes also mention another option, though distal humeral hemiarthroplasty. Less common.
Less common than TEA for trauma, yes. Hemi means replacing only one side, just the distal humerus side, and letting it articulate with the patient's own ulna.
Okay. What are the potential advantages listed for hemi?
Well, compared to TEA, the notes suggest it might allow for greater weight bearing, which could matter for some active elderly people. It also preserves the ulnar bone stock, which is good.
Could be a salvage option too, if ORIF fails.
Potentially, yes. And interestingly, the notes specifically state that for elderly patients, hemiarthroplasty might offer superior range of motion and function compared to TEA. That's a specific claim, adding another dimension to the choice.
So, multiple reconstructive options in the elderly, each with pros and cons. Good to know.
Definitely. Okay, shall we move on to capitellum fractures?
Yeah, let's focus there. Less common overall than the big distal humerus fractures, but tricky in their own way, often involving that crucial joint cartilage. Classification first.
The notes use the Bryan-Mori classification here.
Okay, what are the types?
Type 1 is a large bony piece broken off the capitellum, decent-sized fragment. Type 2 is different. It's more of a shear fracture, mainly cartilage with maybe just a thin sliver of bone, sometimes called a Kocher-Lorenz fracture.
Right, mostly cartilage.
Type 3 is comminuted. The capitellum is smashed into small pieces, also called Broberg-Mori. And type 4 involves both the capitellum and the trochlea, the other part of the distal humerus joint surface.
Got it. And how does management line up with these types?
Generally, ORF fixing it is recommended for displaced type 1 fractures because you've got a decent bone chunk to fix, and also for type 4 because you need to reconstruct both articular surfaces.
What about the others, the cartilage shear or the comminuted ones?
For the comminuted type 3 or a displaced type 2 where it's mostly cartilage, fixation is really difficult, often impossible. So the notes suggest excision removing the loose fragments is often the way to go.
Makes sense. What about the surgical approach if you are fixing an isolated capitellum fracture?
Typically a lateral approach. And here's that link back we mentioned earlier regarding blood supply.
Avoiding posterior dissection.
Exactly. The notes reiterate that point strongly. Avoid stripping the posterior aspect because, again, the main blood supply to the capitellum comes from back there, according to Yamaguchi.
So damaging that could kill the fragment you're trying to fix.
Precisely. And the notes draw that parallel to pediatric lateral condyle fractures, too. Same reason you're careful posteriorly there. It's all about preserving that blood supply.
And finally, just to close the loop, if you have a capitellar fragment as part of a bigger distal humerus fracture,
like a coronal shear component.
That's often when you need that orthogonal plating setup we talked about earlier, maybe with a posterior plate.
Correct. That configuration can be essential to buttress and fix that specific type of fragment.
Okay, crystal clear. Let's move to the last fracture type for this deep dive. Olecranon fractures. Back to the ulna.
Right. These might seem simpler than distal humerus fractures sometimes, but they're very common, and getting the treatment right matters a lot for elbow function, especially extension strength.
Classification. It's the Mayo classification here, right?
Yes, Mayo classification. Based on displacement and stability, type 1 is undisplaced or minimally displaced. basically stable.
Okay.
Type 2 is displaced, the fracture gap is significant, but the ulnohumeral joint itself is still stable, not subluxated.
And type 3.
Type 3 is displaced, and the elbow joint is unstable. There's associated subluxation or dislocation.
And there are modifiers, A and B.
Yep. A means it's a simple, non-commutative fracture pattern. B means it's comminuted, broken into multiple fragments.
So how does management follow that? Simple type 2A, for instance.
That's the classic indication for tension band wiring, or TBW.
Explain the principle there quickly.
The triceps pulls the Olecranon fragment proximally, trying to distract the fracture. The tension band wire is placed anteriorly across the fracture, converting that distracting force into a compressive force across the fracture gap when the elbow bends. Promotes healing.
Clever, but what if it's comminuted? Any B's type.
Tension band wiring doesn't work well for comminuted fractures. You can't get stable compression across multiple small bits. So for comminuted patterns, plating is generally the preferred method, usually a posterior plate.
Okay, now, for those simple displaced type 2A fractures, the notes mention the choice between TBW and plating. There's evidence comparing them.
Yes, referencing studies like the Duckworth et al., RCT. The interesting finding is that overall clinical outcomes, things like elbow function, range of motion, patient-reported scores, tend to be pretty similar between plating and TBW for these simple fracture patterns.
Really? So why choose one over the other? Complications.
Exactly. That's where the difference lies, and it's a key point for counseling patients. Tension band wiring has a much higher rate of symptomatic hardware. Those pins and wires can be prominent under the skin.
So patients often need them taken out later.
Yeah, the removal rate for TBW hardware is high, maybe around 60–65% in that Duckworth study. Plating had lower hardware removal rates, maybe closer to 40%.
But plating had other issues.
Plating was associated with a slightly higher risk of infection and potentially revision surgery in some data sets.
So another trade-off. What's the clinical takeaway from the notes?
Often, for simple fractures, the more cost-effective tension band wiring is still favored initially, but you absolutely have to counsel the patient up front about that high likelihood, maybe 2 out of 3 chance that they'll need a second operation just to remove the hardware because it becomes bothersome later on.
Managing expectations. Crucial.
Very.
Okay, so we've covered quite a bit of ground there. Distal humerus, capitellum, and Olecranon fractures. We've hit their classifications.
Delved into the management strategies, ORAF, replacement, TBW, talked about approaches, plating principles.
Touched on specific challenges like the ulnar nerve, HO prophylaxis, and looked at some of the key evidence, like McKee for elderly distal humerus and Duckworth for Olecranon fixation.
Yeah, you can see how the classification really drives the initial thinking. But then patient factors, the specific fracture pattern, surgeon preference, and the evidence all feed into that final decision. Fixation versus replacement, approach choice, plating configuration.
And understanding these specifics, the classifications, the rationale behind different techniques, the potential pitfalls like nerve issues or hardware problems, that's really essential, isn't it? Especially for exams, but also just for being a competent surgeon.
Absolutely. It's knowing the why behind the what. It moves you beyond just following steps to actually understanding the principles.
Which brings up a final thought, maybe something for you, the listener, to ponder. When you're faced with one of these complex fractures in your own practice.
Yeah, how do you truly balance everything? You've got the biomechanical ideals from the lab, the clinical outcomes from studies like the ones we mentioned.
And then you have the individual patient in front of you, their expectations, their job, their activity level, their bone quality, their other health problems.
Plus the known risks and complications of each specific procedure, and even the cost effectiveness. How do you weigh all that up to make the best choice for that particular patient?
It's rarely a straightforward formula, is it?
Not often, no. It's the art and science of orthopedics, really.
Definitely something to keep thinking about. Well, that wraps up this deep dive into these key upper limb trauma concepts.
And remember, this discussion was based on the Ortho Made Simple notes, which you can find at mokyingren.sg.
We really hope this has been a valuable session for you, helping to consolidate your knowledge on these important fractures.
Thanks for diving deep with us today.